Hello, my name is Leslie Nwankwo, MSN-RN, doctoral candidate in the Nurse Executive Leadership track at the University of South Alabama. The title of my DNP project is Using Structured Huddles to Increase Staff Satisfaction Through Improved Communication and Teamwork. This quality improvement project set out to examine three major elements: communication, teamwork, and staff satisfaction. When we take a look at the first element of communication, effective communication between members of the healthcare team is a vital component in the creation of successful teams. Effective communication supports teamwork among healthcare staff. However, communication failure between clinicians accounts for the majority of medical errors in the healthcare setting. Communication significantly impacts staff satisfaction and plays a huge role in the quality of services rendered in the delivery of healthcare. The second element that was measured was teamwork. Successful teamwork is vital to achieving high-quality care outcomes for patients and involves effective communication between members of the healthcare team. Teamwork, if done well, supports effective communication and promotes staff engagement. The third element that was measured in this quality improvement project was staff satisfaction. Positive staff engagement requires communication and teamwork among members of the interdisciplinary team. This results in staff satisfaction and increased organizational performance. Teamwork cultivates a state of empowerment that gives staff the feeling of being heard, while creating an environment for decreased burnout, increased job satisfaction, and improved job performance. Communication failure and a lack of teamwork have been identified as being the most prevalent contributing factor in over 60 to 80% of all adverse medical events. According to the Journal of Patient Safety, 10% of all deaths in the U.S. are a result of medical errors, making it the third leading cause of all deaths in the U.S. annually in the acute care setting alone. This is followed by heart disease and cancer. A study conducted by the Johns Hopkins University also stated that 250,000 people die annually due to medical errors. And most of these medical errors, which are highly preventable, are due largely in part to poor communication and teamwork between members of the interdisciplinary team. Inadequate communication and teamwork can be a major source of employee dissatisfaction, low employee morale, and disengagement in the workplace. The ultimate consequence of poor communication and a lack of teamwork is increased patient harm due to the decreased levels of safety and poor quality of patient care. The need for this QI project was born out of the fact that poor communication and teamwork across departments within an ambulatory care clinic resulted in negative consequences such as uncommunicated results to patients from providers and staff, unwarranted loss of medication and supplies, duplication of services and fragmentation of care, needless rescheduling of patient appointments, miscommunication among staff, and a lack of clarity in the workflow process, just to name a few. Poor communication and teamwork often result in low quality of care, as these are just some of the various factors that contribute to poor patient outcomes and decreased quality of care. A gap analysis revealed the following. Employees do perceive communication and teamwork as needing to be improved, both inside and outside their departments. Employees' dissatisfaction and staff disengagement result in low employee morale, and a lack of knowledge and information regarding best practices exists within the clinic. A lack of an established structured framework for communication and teamwork also existed, as well as the presence of a multi-directional culture that is fragmented. This also contributed to a lack of communication and teamwork across departments. The purpose of this quality improvement project was to examine if the use of structured huddles would increase staff satisfaction levels among multidisciplinary staff through improved communication and teamwork across various departments within a safety net ambulatory care clinic. The PICA question that was used to guide this evidence-based intervention was as follows. Will the implementation of a structured interdepartmental SPAR team huddles increase staff satisfaction levels through improved interdepartment communication and teamwork? The overarching goal of this quality improvement project was to increase staff satisfaction levels with interdepartmental communication and teamwork within 3 months. This was to be achieved through the following 3 objectives. 1. To increase interdepartmental communication by at least 50% within 2 months. 2. To increase interdepartmental teamwork by at least 50% within 2 months. And 3. To increase staff satisfaction levels to at least 80% within 2 months. Ethical considerations consisted of the organization leadership's team granting permission for this project to be conducted, along with the Institutional Review Board of the University of South Alabama, who also granted approval as exempt status for implementation of this evidence-based project. The appropriate consent forms were given to participants, informing them of their rights and expectations with regards to participation in the project, and no incentives were provided for participation in this quality improvement project. Participants that were selected for this project were drawn from a convenient sample comprised of the executive leadership team, the CEO, the COO, the clinical director, as well as managers and frontline staff from each department. These departments included medical, dental, patient access, pharmacy, information technology, human resources, finance, development, administration, and volunteer services. The inclusion criteria was comprised of English-speaking staff that were full-time and directly employed by the clinic. Exclusion criteria involved any part-time staff, non-English speaking employees, volunteers, or individuals that were contracted for healthcare services. The number of participants in this project were 50 full-time staff, N equals 50. Participation was encouraged through a friendly invitation letter explaining the purpose and significance of the intervention to improve communication and teamwork across departments, for supporting a collaborative work environment. The setting for this project was a mid-sized faith-based charity clinic catering to the uninsured, averaging approximately 4,000 ambulatory care visits per year. The clinic is situated in the heart of a major metropolitan city located in the southeast part of the United States and receives many referrals from numerous partnerships and institutions located close to a large and well-renowned medical center. The physical layout of the clinic is such that the departments are fragmented over 3 floors in a building that is shared with another tenant. The location of the team huddles took place in both a face-to-face and remote meeting platform. This was done to accommodate for the COVID-19 pandemic restrictions. Huddles were divided into one in-person huddle in a large multi-purpose room and 2 huddles that took place on a remote meeting platform via Zoom. There was some initial pushback from supervisors about having to attend in-person huddles 3 times a week, so a compromise was reached to include 2 remote huddles versus 3 in-person huddles to ensure consistent attendance over the 8-week period. Data measurement was achieved through both qualitative data through observation of huddles and huddle pre-work and debriefing, as well as quantitative data through the pre- and post-questionnaire and survey that were utilized for the collection of data in this project. All staff that met inclusion criteria for this project participated in both the pre- and post-questionnaire and survey, while debriefing with huddle facilitators and frontline staff was performed before and after each huddle. Tools used for quantitative data collection for this project included the use of the Huddle Observation Audit Tool and the self-administered pre- and post survey using the satisfaction of employees in healthcare and the Team Steps Teamwork Perceptions Questionnaire. Invitations to participate in the questionnaire and survey were generated through the distribution of the measurement tools clinic-wide to all full-time staff via email. The evidence-based intervention for this project started with the development of the huddle team, comprised of the targeted participants, which included executive leadership, managers, and frontline staff from the 9 departments. From the leadership team, a guided coalition of department leaders were established and served to facilitate commitment and sustainability of the QI initiative. Participating frontline staff acted as observers and coaches for broad-based action in their respective departments. The next step involved the development and implementation of the educational in-service training that took place prior to the implementation of the evidence-based intervention. This served to highlight the importance of effective communication and teamwork. This also created further buy-in and encouraged the participation of all participants. After the educational in-service was provided to the managers and frontline staff, the distribution of the questionnaire and the survey preceded the implementation of the structured team huddles, which immediately followed the structured huddles. These huddles were facilitated by a rotating facilitator and frontline staff from each of the 9 departments, utilizing a structured S-bar communication technique that fostered teamwork and collaboration. The huddle took place from 9:03 a.m. to 9:18 a.m. 3 times a week for a period of 8 weeks, 1 on-site in person and 2 via remote platform huddles to promote huddle attendance. An odd 15-minute window of time was intentionally selected to promote punctuality. The clinic begins operating at 8 a.m., and that gave department managers a chance to assess their departments prior to the huddle for any last-minute issues they wanted to discuss. Pre-work prior to each huddle was performed prior to each huddle to ensure that information shared was specific, pertinent, and actionable to prevent discussion that was general and repetitive that could potentially result in boredom or the drop-off of huddle participants. The S-Bar huddle agenda form was provided to all participants to help guide their selection of specific information to be discussed in the huddles. This included categories such as clinic-wide updates, department-wide updates, immediate goals, ongoing metrics, open staff positions, employee recognition, and so on. Each huddle was guided by the structured S-Bar communication tool to ensure that the huddles ran smoothly and that frontline staff associated with the department team leader were working together to facilitate the huddle. The project manager observed every huddle using the huddle observation tool and also met with each facilitating team member and team leader to make sure that the huddle's pre-work was effective. The project manager also met with the project facilitator and frontline staff to debrief and review opportunities for growth and improvement for future huddles, and other data collection was taken as well using the huddle observation tool. The structure of the team huddles provided a safe, positive platform where staff were able to engage as a team to discuss goals and expectations, as well as address immediate issues that the clinic was facing, and offer insights to possible solutions. The quality improvement model utilized for this project was the Plan, Do, Study, Act model. A total of 3 PDSA cycles were used to continuously identify areas of improvement. The theoretical framework was provided using Hildegard Paplow's theory of interpersonal relationships. This theory describes a distinct mechanism for facilitating interpersonal relationship processes, which consists of 4 phases. 1, pre-orientation, which is gathering data. 2, the orientation phase, which was about problem solving and issue defining. 3, the working phase, which is the working major activity phase. And 4, resolution and relationship closure. In this theory, interpersonal processes are generally established between the nurse and the client, but it is also applicable to staff and manager-staff relationships, where psychological tasks are successfully learned. This is essential for other capacities to be fully used to productively improve relationships with others. The statistical analysis of the results of both the TTPQ questionnaire and the SEHC survey were generated by an independent 2-sample t-test that was run using IBM SPSS software. The evaluation of the results overall of the QI project were not statistically significant in that the TTPQ evaluated the staff's perception in 5 categories: communication, leadership, mutual support, situational monitoring, and team functioning. Responses of the TTPQ were tallied to yield a total score, and the mean score of each category was compared to that of the post-mean category of the TTPQ. There was no significant change in the mean scores or any of the individual question items of the TTPQ after implementing the structured team huddles. In the team functioning category, there was a 3% increase in the mean score from the pre to post mean scores with a p-value of 0.371. In the leadership category, there was a 4% increase from pre to post mean scores with a p-value of 0.215. In the category of situational monitoring, there was no difference in the pre and post mean scores with a p-value of 0.959. In the category of mutual support, there was a 0.5 increase from pre to post mean scores with a p-value of 0.823. In the last category of communication, there was no difference in the pre and post mean scores with a p-value of 0.970. When evaluating staff satisfaction, as measured by the SEHEC survey, the mean post scores decreased by 1% from the pre-survey scores with a p-value of 0.644. These scores were impacted by the fact that the number of staff participating in both the post and pre-questionnaires decreased from that of the number of staff that participated in the pre-survey, in the pre-questionnaire. The number of participants in the TTPQ were 38 to begin with and post 21, representing a 45% decrease in participation. With the SEHC, participants were pre-37 and post-16, representing a 57% decrease in participation. Demographics related to the participants were as follows. 90% of the participants were administration, 22% were either department supervisors or managers, 56% were frontline staff who had direct patient contact, and 3% were ancillary, having no direct patient contact or care. The needs assessment conducted prior to the implementation of this project revealed that the clinic's status with regards to communication and teamwork across departments was lacking, and employees perceived communication and teamwork as needing to be improved, both inside and outside their departments. There was a perceived need to bridge the gap between the current level of staff satisfaction and the desired level of staff satisfaction regarding communication and teamwork across departments. The absence of a structured communication framework within the organization justified the need for an evidence-based intervention, utilizing a structured communication technique for improving communication and teamwork. Although the QI project did not yield statistically significant results, subjective findings include reports from several participants, both frontline and leadership, expressing their delight in participating in the structured team huddles because it gave them relevant insights regarding other departments, as well as a platform that gave a voice to frontline staff. Leadership also attested to an increase in staff engagement and morale as a result of their interaction with the entire leadership team, as opposed to only their direct managers within their departments. There was a marked improvement that was also observed in the way that information was shared, due to the use of the structured SBAR communication technique. Other anecdotal findings included positive changes in staff morale, enhanced interdepartmental communication, along with enhanced collaboration, among members of the multidisciplinary team across departments. This project was also credited with the establishment of a structured framework for sharing information using the SBAR technique. A safe platform for frontline voices to be heard was created through increased interaction and bidirectional communication among leadership and frontline staff, as well as the creation of a shared governance committee. The limitations of this project included the limited time frame for project implementation being only 8 weeks, as well as the COVID-19 pandemic that restricted the number of in-person huddles. Strengths of the project involved everyone's willingness to participate and the guidance of the faculty advisor as well as the clinical preceptor. Initially, there were still some questions about the sustainability for the plans for post-project implementation, which will ultimately rest on the support of the leadership team, who were actively engaged throughout the process, and who also continue to be active champions in promoting ongoing interdepartmental activities that will continue to foster the socialization of the practice change, as well as accountability and collateral relationships for improving teamwork and communication over time. The overall consensus among frontline staff and the leadership team is that even though the structured huddles proved to be most beneficial for the entire organization in terms of improving communication and teamwork across departments, leadership voiced their desire for the frequency of the huddles to be reduced to 1 time a week versus 3 times a week. It was felt that there was not enough space and time to generate new information that was not repetitive due to the slower pace of clinic activities, coupled with the lack of continuous effort on the part of leadership. A decrease in the frequency of huddles from 3 times a week to once a week may serve to ensure the future sustainability of the practice change. To conclude, this QI project was aimed at increasing staff satisfaction levels through improved communication and teamwork via the implementation of structured huddles. This project was guided by the use of the PDSA quality improvement model and Peplow's theory of interpersonal relationships. The 8 weeks of the structured team huddle intervention was implemented after an educational in-service, as well as the distribution of the pre and post TTPQ questionnaire and SEHC surveys. Although the results do not prove to be statistically significant, many of the anecdotal and subjective findings support the evidence in the literature regarding the benefits of structured team huddles. Thank you for your time and attention. For more information, please email me at lnn1421@jagmail.southalabama.edu.